Hi, everybody. Welcome to the Faithbridge Family Gathering Special Edition. I wanted to put something up that was a little bit ahead of schedule when we normally do it because the content is so relevant and so timely right now, today. Recently, our governor gave us the permission to potentially reopen churches. And on the one hand, we pastors are certainly appreciative of the support and the freedoms that gives to us. At the same time, I began noticing in conversations that I was having with pastors of all size churches all around the city, there was this sense that brought to mind the word picture of a bunch of 16-year-olds that were just handed driver's licenses. And they never had training or coaching or education on it. And so they're a little excited at the prospect of it, but they're a little terrified at the thought of doing it without someone showing them, here is how you do it, here's what would be safe. We've never come out of a lockdown. We've never had a pandemic. And so this is all uncharted territory. And so after trying to set my watch according to other people's watches, or they calling me and setting their watch according to my watch, I said to myself, I've got to get up above all of my pastor friends, and I've got to put aside the politicism in the media. I need to get straight to the epicenter of the medical center of Houston. I need to talk to somebody who really knows the stuff about medicine and science and has some data that could help us make guided decisions. To that end, I arranged and was very grateful to be taken up on the offer to interview Dr. Marc Boom. I've been looking forward to talking to Dr. Boom because he is the CEO of the Houston Methodist Hospital System, the whole system, and he is also chair-elect of the Texas Association of Hospitals as well. And in addition to these credentials, he is an MD medical doctor. And so welcome, Dr. Boom.
Thank you, Ken. It's nice to be here.
Well, so I want to talk with you because here I am, a pastor of a large church, and I have lots of pastor friends, some of small churches, medium, large-sized churches. I think we all feel like 16-year-olds who somehow got our driver's license, but we never had a trial run. So it's not like any of us really want to jump in and go first because we don't want to botch it up. And there's not really any education manual that we can look at. And so it's for that reason I said to myself, I need to get outside of talking to clergy people, and I certainly need to get outside of listening to politicians. I need to talk to Dr. Boom and ask him some questions. And so, first of all, how are you doing? How is Houston Methodist doing? How's our city been holding up through all of this?
Well, thanks for asking. We're doing well. Very, very proud of the team of hardworking men and women across our system who've really put their lives on hold to care for so many Houstonians in need. The good news is we appear to have peaked, and we're seeing some numbers come down within our hospital system, which is obviously very encouraging and taking some of the pressure off of those individuals. And that's just some good news as we start moving towards a new normal sometime soon.
Right. Well, and so while we're there, I would be remiss not to say a thank you to you and to the countless medical staff and doctors, nurses, and all around our city, certainly in our system, but in all the systems, all around the country, all around the world, who have truly been laying down their lives and serving on the front line. And I know some of them are going with great sacrifice, even those exposed most closely to the COVID situation, not able to go even in their homes with their children when they get off of work. And so I've seen these photos of them touching through the glass and this sort of thing, and our hearts just go out to all of you. Thank you for your leadership.
Well, thank you. A number of my colleagues, both in nursing and as physicians, have said, this is what we trained our whole lives for, and it's, what we have been called to do, and they really have answered the call beautifully, and I'm very proud of all of them.
I'll say. So here we are where I'm doing life and ministry. We're in the suburbs of Northwest Houston. Out here in the suburbs, I have some friends who I think probably because sometimes the suburbs are a little slower, a little less dire feeling. Some of my friends who are saying, see, the sky has not fallen. I think a lot of this was hype. Let's just get back to normal now. And so I find myself wondering, okay, is that right or wrong or somewhere in between?
Well, let me be clear. I would like nothing more than to get back to normal, as all of us would, right? That's of course what we all desperately want right now. This has been a very difficult period of time for everybody. I think when we look at the curves and the data, we can say definitively that what we did, the sacrifices that were made, the difficult decisions that were made across our community have ultimately saved lives and prevented a situation in Houston and in greater Houston that happened in places like New York City, that happened in New Orleans, that happened, certainly in the northern region of Italy and Wuhan, et cetera. I have no doubt this virus is a bad actor. It spreads very, very easily. And what happened ultimately was that the restrictions that were put in place and that ultimately all the sacrifices we all made have helped keep this curve from getting out of control. I have no doubt that had we not done that when that was done across our region, we'd have experienced something just like those other cities. So I do not believe at all, in fact, firmly, that there was any overreaction. In fact, what we're seeing today is strong evidence of the success of those measures that were put in place. You can actually watch that march through time-wise right when we would have expected it to in terms of our curve.
Fascinating. So check my thinking here. Sometimes it helps me to put things into word pictures. I have pictured in my mind COVID-19 sort of like a big pot of noodles on the stove. And of course, when you're young and you do your first spaghetti, you learn quickly. If you crank it up all the way high and you put the lid on, it's only a few minutes until the bubbles come up and frothy bubbles are everywhere and it's spilling out. And then you learn to pitch it back and keep stirring, and then you don't have this mess. The picture that I have in my mind is that the goal of the medical community and for all of us to get the curve down was never operating with the assumption that we would just eliminate the virus by the end of the spring or the summer, but rather that we would press the curve down and keep the virus at a low simmer, because it's not going away, as I understand it, till we get a vaccine maybe. So that we didn't have the surge point, the boiling over in the hospitals, as did happen in some of those cities. Do I have a clear understanding? Is that a word picture that works?
I love that picture. It's a great picture. Actually, it's very similar to a picture one of my colleagues, Bill McKeon, who's the CEO of the Texas Medical Center, will often use in terms of how do we start loosening restrictions. And he'll describe the current scenario as if we had shaken up a big bottle of Coca-Cola. And we all know from hard experience, if you open that up too quickly, it's a big, big mess. And so what do we learn to do? We learn to slowly sort of ease off a little and we're going a little too fast, and then we turn it back down, et cetera, and ultimately allow the pressure to release. So both of those are great analogies for the situation we're in. The cold, hard reality is this virus hit much more quickly than the country or the world were ready for, particularly from a public health infrastructure. And the only real option to flatten the curve and to prevent that overwhelming healthcare crisis and lots of death and loss of life, et cetera, was to put these very draconian and very difficult restrictions in place. The goal going forward needs to be to take those off slowly and carefully and gradually, to do that with the data behind that. So as we watch each thing get released and each restriction get released, that we make sure we don't go too quickly, but we go as quickly as we possibly can. That's got to be the goal, of course. But we're going to live with this virus for quite some time. So as I said earlier, it's a new normal. We will not be back to the way it was for quite some time.
Yeah. So let's stay there just for a minute, because I think I'm certainly interested, and I suspect a lot of people are. I hear it said, and I'd like to hear a real doctor say something about this, that maybe, this is a maybe, in the summer hot months it subsides, especially in the aftermath of all of the lockdowns and shutdowns. And maybe it stays good for the summer, just at a low simmer. But any number of people have been projecting, yes, but then bring the cold weather back. bring people out of the outdoors back inside, as happens in the winter, and we're likely to see a resurgence or another curve that might even be compounded by the overlapping curve that already will be there, because every year there's a flu curve. What are your thoughts on this?
Yeah, I wish I had a crystal ball. That is one of those, trillion-dollar questions that's out there, no question. Excuse me. This virus, because everybody in the population, other than now, a small percentage of people who have had the illness, are still immunologically naive, meaning they've never seen this. So, and we live in a world that's air conditioned. So the reality is it's unlikely to completely peter out due to temperature. It may have some dynamics, and that may have helped us in Houston as well, that it didn't spread quite as easily. But in terms of it going away, most of the epidemiologists are saying they don't think that will happen. Had we had, more like the flu, it might, or more like seasonal coronavirus, because we see some very mild coronavirus. There's 4 different strains every year that cause infections that are nothing like this. Those go away in summer, but much of the population has some immunity. There is a very valid question, though, when these sort of spreadability conditions that we saw in New York, where things are cooler and drier than in Houston, where things are warmer and more, and moister, a lot more humid, whether we see some increase in the fall. That's an unknown question. I think your analogy is great, because I think what we're going to do is we're going to have a pot of pasta on the stove, simmering along for months and months and months. And, each time we're not, that lid gets in a little bit the wrong place, we're going to have that problem of it boiling over. So I think this next period of time is going to be one of slowly reducing restrictions, but at times, particularly in hot spots, maybe having to turn back up some restrictions. Hopefully nothing like what we've done, but much more titratable, much more mild types of restrictions. But, again, we don't know that for sure, but I would expect months and months and months of, active monitoring of the situation and, turning on and off of some of the controls that we would have.
Okay, great. So let's go a little further into that. I've read all about the gates, gate 1, gate 2, gate 3, a certain number of days. So I find myself as a pastor asking the question, okay, which gate makes it safe now to bring people back? And the flip side, what are you in the medical world looking at? What are these markers that you're looking at, which if it starts going up, you're like, uh-oh, nope, we got to go back down? Can you talk a bit about that?
Sure, that's a great question, and you'll see in the next, within the week, you will see public data released through all of the Texas Medical Center hospitals of some of those gating criteria. There's been actively at work. I mean, I spent 2.5 hours this morning, on conference calls, Zoom calls with different groups, from the TMC CEOs to, the county officials, to both of the czars that are in place. We're on an hour-and-a-half call with a number of us this morning. So as business is figuring out, and faith community and everybody else are figuring out, how do we slowly ramp up, we at the medical community are trying to give those gating criteria to say, okay, here's when we know that we believe that we're okay. None of us know this. This is a whole new playbook, back to your, we just got our driver's license but have never driven a car. But as best as we can, what are those indicators that say, yeah, we're comfortable going to the next step? But as importantly, or maybe even more importantly, what are the flags that we're going to look for? What are the warning signs we would see that say, you know what, we're not quite to that next step, and we better even back off just a hair? So there's a number of things we're looking at. Right now, you can look at the number of new diagnoses in the community on a daily basis. It's running in the low, I think 205, 210. I don't recall yesterday. I think it was 205, something like that. But it's been bubbling around now for about a week at a plateau. And David Purse, who heads up the city health department, he's an emergency room physician, great guy. He said it well on one of the calls, which is, we're kind of seem to maybe be finding this new equilibrium with the virus at that level. That's a level we look at from the hospital systems and say, okay, we can manage that level. But the challenge is, as we ease restrictions, there's bound to be sort of a new equilibrium level, because we know even with all the protections in place and everything, there'll still be a whole lot more connections, which is a good thing, of course, between people, but from a viral perspective, may be a very bad thing. And so what we need to be able to do then is say, okay, let's turn some things on. Now let's go through sort of a 1 to 2 week cycle, probably closer to a 2 week cycle. And assuming all the indicators look good, okay, now we'll go to the next level. So that's one indicator we're looking at. Another is ICU capacity, because we know from early points on the curve, we were seeing over the course of a week a tripling of ICU volume. So in 1 week, that's triple. In 2 weeks, that's 9x. In 3 weeks, that's 27x. That, and that's without, that could even amplify further than that, depending how things go in the community. So we know there's sort of a warning point where our ICU capacity, and we're seeing the ramp up be fast enough that we might wake up 2 weeks from now in a whole world of hurt, and certainly in 3 weeks later. And those may be times to sort of slow some things down. So we're looking at a number of other indicators, but you'll see a couple like that I think will be the medical community's, sort of contribution to the decision makers to say, hey, we're doing okay, or we need to slow things down, or no, it looks really good, we can speed things up, we can go to the next phase. And I think we'll go through those different gates together, but it takes a little time to pause. So you loosen things up. Now you assess, how did things change? Did things get out of hand? Are they causing us concern? Well, let's wait a little longer. Or, you know what, we're a week to 2 weeks in and we're doing great, and we're still seeing a level that's manageable. Let's move to that next gate. Let's, et cetera, et cetera. And I think that's how things will progress.
So let's get down to brass tacks in my world. You're talking to a lot of preachers, and we're all sitting there taking notes. So staying with the gate metaphor, what are we're in gate 1 right now. Isn't that correct?
Not even gone. Yeah. We haven't even gone through it. Yeah.
We haven't even gone through it. What gate do you believe is wise for churches to see that we communally have gone through before we would even talk of
Sure.
Now let's talk about how we would do our openings.
That's a great question. And look, at one of the most frustrating things, I'm sure, for all of you as preachers, as leaders of congregations, certainly for all of us as people who want to attend, just at a time when we kind of need it most, it's not there in the ways we're used to. So it's been really tough for everybody. Thankfully, thank goodness we live today with all the digital means we have, that you and I can
Amen.
do this, and that I was able to attend church service digitally. I mean, can you imagine 30 years ago? It would have been a different story, and really even that much harder. The reality, though, is that, churches are one of the most concerning areas for the spread, because you put a lot of people together in close proximity for a long period of time. And, I think many congregations also experience that, they see maybe a disproportionate number of older people, attending church than some of the young. That's obviously maybe an issue in our society, but it's a reality also. And those are the very people who are at most risk. And so churches, unfortunately, places of worship, are going to have to be on the more cautious end. Because when we do see easing of restrictions, perhaps we'll go from, groupings of 10, which is right now the advice, to maybe it'll be a group of 50. I mean, none of us know for sure, because we haven't yet seen all of the detail of the different plans that are coming out, certainly at the time that we're recording this. But I think 50 is going to be the lid for probably at least May, as this next gate. And the next gate's not going to allow a congregation that has, 2,000 members and has 1,000 in a worship service. That's not going to be a gate that hits that soon. The next gate after 50 may be that we ease up and say, okay, 100 or 250 or something like that. And so I do think through the month of May, at best, we're looking at small groups of 50. So perhaps, with some spread out, obviously some smaller churches might be able to meet with a lot of caveats I'll give you in terms of how that needs to be set up, or maybe, a few Sunday school classes or other things like that, but really thinking about the vulnerable populations as well. The people with underlying health conditions, people who are above 60, certainly, they really shouldn't be participating in that, in my opinion. Even then, those individuals need to stay more careful. So really all of you need to be thinking about how do you continue to serve your congregation digitally and connect people those ways for quite some time, I think.
Sure. So a document was going around that a number of pastors signed saying, we, the undersigned, with all respect to all government authorities that are giving freedoms, we still believe it's wise to wait at least through May before we open up. I went ahead and signed it. I didn't get to talk to you first, but I am hearing that you don't think that was too conservative.
No, I think you were right on.
Okay.
I think you were
Good.
right on with that. That was right, the correct thing to do. In fact, Bishop Jones had called me and asked me if I would discuss that among all the CEOs and whether we'd support that. And with strong unanimity, we all support that is the right thing to do.
Good. All right. So, yeah, because I guess when it comes to churches, certainly larger churches, we would be most similar to theaters, to sports arenas, because you're putting a lot of people in pretty close together in a normal world, or the old normal. And so let's just keep going with it a minute. If suppose I just asked you to throw a dart at the wall and say, okay, not May, maybe June, maybe July, August, September. Do you think that large churches could be talking about September? Could we be talking about as long away as 2021?
Yeah, that's one of those crystal ball questions. I will say I'm hopeful, and I'm going to preface this with, this is just hopeful that as we ease restrictions, we get through those gates and everything else. In that mid-June, July timeframe, we may be able to see some churches able to do some creative things to get a couple hundred of people in a worship service. Now that's going to require, a setting that, in the church that's much larger than 200 seats. If you want to put 200 people there, they're going to need to be spread out. You're going to take groupings of, a couple who come to church together. Again, not the most vulnerable. The most vulnerable are going to need to be staying out. So this will be, younger congregants and those who, probably under 60, and those who don't have underlying health reasons to give them concern. Those individuals I would really strongly counsel, probably for a longer period of time, are worshiping differently. But you may be able to go during that time to, taking, let's say, a church that holds 1,000 members at peak on Sunday, on Easter service or Christmas Eve or whatever that might be. And, maybe put a couple hundred people in there with a cluster of a family of 5 over here. And then you got to go at least 6 feet and have a family of 4 over there, and 6 feet, you have a couple, who worship together. So it's going to be very, very different, with prolonged periods of time in between services to go through and really wipe down and clean and sterilize all those surfaces. Things like passing a common collection plate just can't happen. Things like taking communion, whichever method obviously gets used in different churches, but passing, by the wine or passing by the bread that's broken, that just can't happen. I know that's obviously problematic and troublesome for all of us who worship, but those are areas where there would be very high risk. And I will tell you, I think it was in late February, I went to a funeral, and it was at an Episcopalian church where you walk up and take communion. And I sat there kind of horrified, to be honest, because this was coming and we saw it coming. And, I felt like I wanted to go do communion, but I did the cross your arms, just get the blessing without actually taking it, simply because I thought it was unwise. And that's going to be a reality that we're going to face for a while there as well. So then if I need to throw a dart, that's a tough one, because I'll tell you what, putting 1,500 people together in a very large congregation, as you said, that's like movie theaters, that's like concerts, that's like sporting events. I find it highly improbable. For instance, let's go the other end of the spectrum. I don't think most likely the Houston Texans are going to put 80,000 people in NRG for a game. They may put 10,000 people there. I don't know what that's going to be. They may play against an empty stadium. Who knows? But I'll be surprised. Boy, I'll be pleasantly surprised if we can pull that off, but I just don't see it. So the 1,500, 2,000 member congregation or larger congregation, maybe with a service that's that large, it's going to be really hard to do the kinds of things with social distancing. And if what's correct is we will live with this virus until we get to herd immunity, which is most likely through a vaccine, the reality is I don't see having completely normal, I think you'll be looking at, if you want to get people in person, you'd be looking at saying we have to have more frequent, a bunch of different services. We usually have 3, let's have 8, I'm making this up, but let's have 8, and we'll spread them. If they're usually spread out by 20 minutes, we're going to have to spread them out by an hour so we can go in and clean. I mean, those kinds of practices are probably going to be a reality that we live in.
Wow. That's as helpful. It's sobering, but this is what we need. So I was going to ask you, Dr. Boom, if you were in my shoes, if you were a pastor, but that's not a fair question because you're not, and I couldn't answer if you flipped it on me, if I were the CEO of the hospital. So I'm going to ask it this way. What, as a lay person, knowing what you know, with all your medical knowledge, what would you say would be 3 or 4 irreducible minimums that you would want to see that your church, when that day comes, let's say it's August or whenever, you say they're doing this, I feel they're being responsible, and the day might even come that you would say, okay, family, we're going back to church. What would you need to see happening?
Yeah, a lot of that will depend on all the gating criteria I was talking about. So I'm going to want to see that as we've eased up restrictions in many different settings around the community, that we've done so successfully without having, the genie kind of get out of the bottle in terms of the infection and the infection rate. If that's happening, it's going to imply that whether we're talking a church or whether we're talking a concert or whether we're talking, a restaurant, they all have different dynamics, of course, but that we'd be able to put more people together in closer proximity. For quite some time, I probably would be wearing a mask to protect others that I'm around. Masks actually do much more to protect the people around you than they do to protect yourself in the community setting. It's about me not accidentally leaving virus through droplet spread somewhere on a pew, on whatever surface that I'm sitting near or walking near. Because I clear my throat, because I cough. And we know there's an asymptomatic period with this. We know some people may never have symptoms. And those are, really good news, obviously, for those people, really bad news when you talk about spreading a virus. And so, probably wearing masks, being spread out, and having enhanced cleaning practices that I observe would be, some of the big things that I'd want to see.
Would you... I believe that you and all the people in hospitals, you have to have your temperature taken before you come in.
We do.
Every day. Yeah. Do you, should we churches be thinking about, we better go buy 50 forehead thermometers?
Yep. It's an interesting question because I will tell you, we do that every day, and we've had very few people we've had to send elsewhere, or turn away as they come to the hospitals. I mean, I get my temp measured every time, you walk in. I mean, and literally I'll walk outside to go talk to a reporter or something like that. And, 2 seconds later, I'm getting my temperature checked again because that is our rule, right? And it does a couple of great things, though. It does force everybody to think about it. It does set the tone that, hey, the world's not normal. Human nature is such that we're all going to want to just be as normal as we can be, or normal as it used to be, and we won't be. And so, I think setting that tone is a good thing. And, if you do find somebody, it is an opportunity. You've helped them because they need to go get checked. They need to go home. They need to call their physician. They may need to get tested for coronavirus. And so I think you provide a good service. I will tell you, the infrared digital thermometers are a quick, easy way. They don't create a big backlog. That's what we use. They're not wonderfully accurate. In other words, they're not, as accurate as if we did a core body temperature or an oral temperature, rectal temperature like we can do. But they're pretty good. And when we actually studied that early on, because we knew that taking somebody's oral temp every day, both it goes through a lot of supplies, obviously, because you have to have the different covers and things like that, but also really would slow things down. So we tested these. Actually, I was part of our own little test group where we did our own little study. If anything, they tended to overcall temperature by a few tenths of a degree, which you'd rather overcall than undercall when you're making those kinds of decisions. But generally, we're overall accurate. They need to be applied well. So if you get a goofy reading, and I've seen this happen in some places that I've gone outside, and somebody gets a 92-degree temperature, that's not obviously a plausible temperature. The thing's not working. So then you need to say, well, hold on a second, let me have you get checked on the other one. Not, oh, you're fine, just come on through. But by and large, if you have that, you could screen people pretty quickly. It would give you certainly give everybody some more confidence. I cannot tell you 100% it will dramatically change the risk profile, but it certainly is a pretty cheap, easy thing to do.
Yeah, that's helpful. And the word confidence that you just mentioned, I think is salient to this conversation, because I think probably those of us who work in churches, we can't wait to get back in to just get it going again. But I think we pastors and leaders are going to need to be considering the emotional trauma that just being pulled out and set on the bench for 6, 7, 8 weeks, whatever it kind of is or will be, that's going to create quite, I predict, some sense of anxiety for people who are like, I do want to come back. I want to watch some other people do it 2 or 3 weeks, see how it goes for them.
Yeah.
Am I tracking along? Is that kind of
it's the old Life cereal commercial, right? Let Mikey try it, right? Wasn't that the old commercial? Yeah, you know, it's interesting because we're going to see the whole end of human, emotion and behavior. There are some people I talk to who are so ripped, ready to go. They're going to do anything, throw caution to the wind. And, that's a big concern because that's not what we all need as a community, as social contract of taking care of each other. There are going to be other people who are more conservative and more cautious and take a wait and see attitude. And, none of us can be wrong by taking a more wait and see attitude, right? Conservatism is always a good thing when you're talking something like this. But the key people that are going to need to have that really conservative outlook are the people who either have personal vulnerabilities or are really close to people who are vulnerable, right? So, I took my parents, my wife took her parents, and, they pretty much stayed at home, except, when her parents don't always follow advice. But mostly, we've had them cooped up at home. It's tough. I mean, it is psychologically difficult for people to do. A lot of support's necessary when, fortunately, we worry a lot about the stressors of this, mental illness and other things that tend to happen in this type of scenario. So getting people back out is a really important thing, but it's got to be done safely. Yeah,
and that's a hard tightrope to suspend, to know that you're hanging it just in the right place.
No question. We're threading a lot of needles, as we go forward. So.
Right, and hats off to you for all of the leadership that you're giving. So let's go to the end game and work backwards a minute.
Sure.
I suppose the ultimate end game would be the discovery of a vaccine that works, that's tested and implementable to billions of people. Mm-hmm. Right. So I watch the news, but I'd rather ask somebody in the medical community. I hear them say, well, that's going to take at least a year and a half. High, low, something in between, or we just absolutely have no idea?
We don't know 100%, but in most best case scenarios, to get herd immunity from the vaccine, which, as you mentioned, is going to require, in the U.S., that requires a couple 100 million people to be to be vaccinated in the U.S. alone. Worldwide, obviously, you're talking about billions of people that need vaccination. And if we're going to turn back on travel and all the different things that this globally connected society does, you really have to do that, across the world to really, get this disease out of the picture. So in order to vaccinate that many people, the vaccine needs to be developed. It needs to be tested. First and foremost, it needs to be safe. And vaccines are incredibly safe. They're incredibly safe because they're usually studied for years and years and years to get to that point. When we're talking, if this was Ebola and 50% of people were dying, you would take a lot more risk, obviously, in putting a vaccine out and giving it to people because, in that case, even a 1 or 2% problem with the vaccine would be far better than a 50% mortality rate. It's something that's roaring wild. In this case, that's not the risk benefit. And so anytime you use a drug, a vaccine, anything else across tens of millions, hundreds of millions, now billions of people, even something that is very, very rare, could affect many, many people. And so it does need to be tested and tested safely. Now, that 12 to 18 month period does not mean there won't be people getting vaccine before then. Right now, some people already are getting vaccine in the early safety trials. I think it's very plausible to think if these things show promise that in the fall, for instance, some healthcare workers or other really high risk people may be part of that next phase of trial. And we may see thousands and thousands, maybe tens of thousands, even hundreds of thousands of people getting vaccination through that time frame to try to understand the vaccine. I know if I were to put out to my staff, hey, who would volunteer? I predict, many would. I certainly would. And so I think we will see that happen across first responders, across hospital workers and others. But to get to herd immunity, we're going to have to get to a point where this covers everybody. Now, you ask, a question also is, are we sure of that? And, I have to be honest, we're not sure that we can develop a vaccine. There's lots of promising signs. There's good reason to believe it's possible based on some work that was done with SARS before. It never got to the point of vaccinating because it went away. And it went away basically because it was so fast, so severe that you knew everybody who had it pretty much. And, many of them died, many of them were treated, but you could very quickly shut down the course of infection, unlike this where you don't know everybody who has it. But we don't know for sure. I mean, think of HIV, right? We changed the paradigm of HIV because we can basically turn it into a chronic disease, but we still can't cure it. Maybe a couple of cases of that. And we don't have a vaccine. And so for, now 3 decades, medical science has worked on a vaccine trial. So it varies by viruses. Most people think, yes, it is achievable. It is achievable during that time, but it is not 100% guarantee that we will have a vaccine in that time. The other thing that could really change the paradigm is if we have some effective therapies. Sort of the test for flu, now give somebody Tamiflu, and we know we can change the course of disease. And Tamiflu is not a wonderful drug. It doesn't just make it go away, but it certainly helps and prevents severity and shortens infection. If some of the things that are being worked on ultimately change the paradigm here, and we could treat people earlier in the disease, prevent them maybe all the way early to prevent them from even needing hospitalization, or perhaps, more likely, I think it would be treating them at some point when they're sick enough to be in a hospital to keep them from needing an ICU and keep them from needing a ventilator and keep them from dying in many cases. That would change the paradigm dramatically, right? Because if the mortality was far, far lower, it would look a lot more like flu if we knew we wouldn't overwhelm hospital capacity as this grew rapidly because we had effective treatments. So the vaccine is not the only paradigm shifting game. That obviously very different scenarios. What would happen with an effective treatment is it could bubble at higher levels in the community because we would know that we were unlikely to have extreme loss of life, an epidemic that raged out of control and overwhelmed health systems, et cetera. So there's lots of work on a number of potential options for treatment, but none that we know work yet. Lots of great work, but none that we can see that's happening.
So I want to ask a question about therapeutics, but let me ask one more question about the vaccine.
Sure.
So the thought occurred to me, or the question occurred to me the other day when I was just thinking about a vaccine. When they talk about a vaccine, are we talking about a vaccine like polio that's like, psh, that works? Or like the flu that you get every year? Yep. Some years they really nailed it. Some years they didn't really nail it. Which kind of vaccine are they are we talking about?
Well, we don't know exactly the answer to that yet. What we do know is the flu mutates, the flu virus mutates constantly and rapidly, which is, and unfortunately, we've never been able to, develop yet in medical science a universal flu vaccine. And so it's always somewhat effective, but never as effective as we'd like it. And then furthermore, only about 45% of the population who should be getting a flu shot get it. So there's that dynamic that happens as well. But then even if you do get it, depending on the year, it may be 50% effective. Some really bad years, it's 20 or 30%. Most years, it's 60 or 70% effective. But you can change the paradigm dramatically, obviously, if you could get that kind of result. Many other vaccines that we give, particularly in childhood, are way more effective than that, and they are longer term. So the flu has to be done every year because of mutating, but many of those vaccines, you have a series when you're a child and you never have one again, or maybe you have a booster at some point. There's some that, as a primary care physician that I am, we give boosters throughout adulthood. Tetanus would be a classic example everybody thinks of with that, to get those kinds of boosters. Diphtheria was another one, whooping cough. There's some others like that need some boosters as well. So we don't 100% know that, but this virus, while it mutates quite a bit, it's an RNA virus, which tend to be unstable. So far, knock wood, the mutations have really been pretty minor. They allow scientists to track where the infection goes and those kinds of epidemiologic studies, but they've not been clinically meaningful. And that's really good news, because that implies, hopefully, that we can get to a point where we can vaccinate and we don't have a coronavirus that continues to mutate. However, even if, say, that were to happen, odds are once they get the first one up and running that's working, and say then the strain mutates, I think it would probably be more like flu, where perhaps we could quickly ramp that up. I don't think you'd be looking at another 18 months if there was starting to be mutation. At that point, you might get into a seasonal vaccination type of situation like we have today with the flu.
Fascinating. All right, so let's go back to the therapeutics. I was very proud to be associated with Houston Methodist. Several weeks ago, the front page, Houston Methodist, is the pace setter on the plasma therapy. Let me see if I understand it. Somebody who's been sick with COVID-19, but now they're well, the theory is you put their blood into the new sick person, and because their blood has the antibodies, the new person might get better faster.
That's right. That's right. So it's a very old concept. It dates back at least to the 1880s. It was used early on in diphtheria. There was a scientist whose name escapes me right now who won the Nobel Prize for this, and really gave the whole concept of how, it really was a precursor to the whole concept of how immunity happens. We were formed in 1919 in the midst of the pandemic flu epidemic at Houston Methodist. That was our first year, December 31st, 1919. And I'm quite sure this was used at times back then as well. So it is a long-standing concept. Basically, the goal is to get antibodies against the virus to the person who needs it. And we know that in the case of a virus, if one gets the infection at some point in time, it varies a little timing-wise depending on the virus. In this case, it looks to be you have to have, for most people, a good solid couple of weeks after you finish your infection, that in the liquid surrounding the blood cells, that's what plasma is. Think of it as the liquid part of blood, not the red blood cells and white cells and platelets and things. It's all the liquid around that. You have all these antibodies and a bunch of other factors there. And so it's sort of the club, not the surgical way of doing it, but the more broad way of doing it is, okay, so let's go get that from somebody and let's give that to somebody who's in need. We've already done, we were first in the country to do it, as you mentioned. Really proud of our team for doing that. There's a multi-center trial across the country doing this. We've had well over 100 donors, so very generous people, some of them whom are donating, because you can donate at least a couple times a week, because only the liquid part of blood, you're not giving up all those blood cells and other things. We've treated 47 people. We're very cautiously optimistic with what we're seeing. The challenge with this is it's not scalable because, it's an hour to go get the blood from somebody and everything else. It's not scalable to treat, tens and tens and tens of thousands of patients. So while it is a very important paradigm for now, the next, as I said, this is kind of the club. The next would be a more sort of surgical way of giving antibodies. And that way would be possibly manufacturing monoclonal antibodies. We use lots of monoclonal antibodies in medical care now. And so when we can identify the antibodies that are there, some of the pharmaceutical companies can then make that in large quantity. And there's huge amounts of work being done right now. To
be clear, for a layperson like me, you're talking about creating an antibiotic.
No, not an antibiotic, but actually the antibodies that are being used. An antibiotic.
But how did it get into the person?
So what they would do is that what they're doing actually is trying to take, and they're using huge pools of plasma right now. When people are donating plasma across the country, either it's going to these types of efforts or it's actually going into these large pools where these drug companies are then working to identify the key antibodies. Then they can actually synthetically make that same antibody, and then you could inject that into somebody. So where we're giving this whole liquid pool that happens to have the antibodies in it, when you can identify the antibody, you might be able to make that through, biotechnology processes, and then be able to inject that. And you can scale that up much higher. So
Because they
that's
can make it
also
in labs over and over.
exactly, and you can make vats
Yeah.
and vats and vats of this stuff. So that's the second way of getting people antibodies that would help them. The ultimate way to get them antibodies is through a vaccine. That's what vaccines do, is they cause your body to make its own antibodies against what you're seeing. You effectively kind of trick the body. You show it, there's a whole bunch of different techniques, but you show it some piece of what it might react to in the virus, either through the old way is you basically, attenuated a virus or killed a virus. So made a virus non-functioning, or killed a virus, but you still had the fragments of proteins and things injected into somebody. And that's what they form antibodies against. The classic original one was cowpox, when they recognized that farmers who dealt with cows who got cowpox didn't get smallpox, and people figured out then that you could actually take scrapings of these pustules, and they were doing something that it turns out now we look back at was probably inactivating those viruses, inject them into somebody, and you'd make them immune. This was about 300 years ago this was happening. And so vaccine will be that ultimate answer how to get there. But I have some cautious optimism, because we just don't know yet. The data is not there yet, but that the monoclonal antibody route may be a very effective treatment, kind of that paradigm shifting thing I was talking about, of get somebody as they're getting sick and give them something that prevents them from getting to the final stages. And so right now, when you look at plasma, the studies that have been approved, and what we're doing is we're giving it to very sick people, hoping that they will be better. And we've sent home a number of people who've gotten this therapy already. So we have some, like I said, some reason for cautious optimism. But I got to emphasize, this is not a randomized controlled trial. There's many other drugs and things we're using in those individuals. So we're seeing indicators, but we don't know this for sure. The next step may be to give this, and that's what we want to study next. How do you give this to people at some trigger point? They come into the hospital, for example, and at some point their oxygen level starts to be a real problem. We say, uh-oh, they're going in the wrong direction. Now let's give them this and prevent that decline. And that's another way we may use this. And that's a way that certainly antibodies may be used in the future.
Would you speak a word about the now highly politicized hydroxychloroquine? Yeah, say the word.
Yeah, hydroxychloroquine. Yes.
Chloroquine.
So it's an old drug, chloroquine, hydroxychloroquine, used to treat malaria, and more recently, hydroxychloroquine is actually used quite commonly. It's called Plaquenil. It gets used for rheumatoid arthritis and some other autoimmune disorders. So it's got basically anti-inflammatory kinds of properties. It's not a particularly safe drug, unfortunately. It has some things that it can do in terms of side effects, in terms of prolongation of one of the intervals on an EKG that can give people some risk. Unfortunately, the studies that have been coming out are not that encouraging. I mean, there was some early data to suggest it might be effective. The jury is big time still out, but there was a VA study recently that wasn't all that promising. So among drugs that our clinicians and scientists are looking at while we are studying it, by all means, and we use it as part of a protocol, because in a hospital setting, it can be done pretty safely. We're far from certain that it works, and frankly, it's not the top couple. Plasma therapy is something we have a good bit of optimism about. A drug called remdesivir, which is an antiviral drug that was actually previously developed around SARS, and it has very good theoretical reason to work. We have some cautious optimism around that as well, but it's very anecdotal still. By the end of the month, Gilead makes that. We expect to start seeing some data around that. We've seen a little bit of good data and a little bit of not so good data out there in very sick populations. So I don't know which way that will go, but those are probably the highest candidates right now. There's a couple oral antivirals that have been developed that are in study. We're not in one of them. One of them is mainly in Japan. Those are possibilities as well. Those are the areas I'd say where most of our clinicians are putting most of their hope. The other piece then is, when you look at people who do really poorly, it seems to be what's called a cytokine storm, which is their own bodies kind of overwhelming their own immune response, having this overwhelming, horrible response that almost is worse than the disease itself. And so there's a lot of work for patients who have that in-house to use a lot of other drugs that can be modulating that. And those could also change the course in terms of if somebody gets really sick, preventing, death and preventing, them getting even sicker. But again, the jury's still out on all of those things.
Got it. So you mentioned pox a minute ago, and that got me thinking about one kind of pox I know, chicken pox. And I think once you get that, I had it, you don't get it again. Do they think that COVID-19 is going to be that, or is it like the flu that you could get every year?
We just don't know that.
We don't know.
I think it's more likely to be you won't get it again. Chickenpox may not be the best example because remember, chickenpox never really goes away, which is why it just goes back dormant, and that's why people get shingles when they're adults, and we vaccinate against shingles now.
Yeah.
So maybe not the best example, but some other, you still are immune for life against chickenpox itself. You won't end up with another bout of the rash and everything else. Where it comes out is usually an older age when your immunity starts to wane a little bit, and it's been hiding out in your nerves and comes back out and causes shingles, which is why we vaccinate against that. For this, we just don't know the answer. I'd say more likely to be something that you have lasting immunity to, but that is a gut feel based on a lot of the literature that's out there and what the virologists and epidemiologists are saying, but far from certain at this point. Certainly something we would expect you could give immunity for some period of time, which is the main thing that'll need to happen, because, you can always boost immune responses, right? And you can always revaccinate. Those are always possibilities. Who knows? That could be what we see as well. We just don't know yet.
Well, Dr. Boom, this has been fascinating, and I'm so appreciative for your time, and I know that many watching share in that appreciation. I wonder if, for the sake of those watching, certainly parishioners of mine and many fellow clergy, if you have any further final thought or word that you would speak to us as leaders of faith communities.
Sure. First off, I'd like to thank everybody, because we wouldn't be in the better situation we are as a community without, everybody looking out for each other. There just would have been no way to have the kind of response we're seeing. And, it's tempting and almost, irresistible for certain people, particularly, when political messages start creeping in, to now say that, hey, we overreacted, or, look, this was no big deal. And the reason it's not been as big a deal, and it is a big deal, let me tell you. The people who get sick and the people who kind of melt away and die before your eyes, and the stories of whole families that have been affected in many cases. This is not the flu. This is not what we're used to seeing in those cases where it's bad, and medical science doesn't totally understand why it's not so bad in some versus the other. But all of those things we did together really bent this curve. And so it's going to be all the things we do together right coming out of this that are going to do this. It's going to, as irritating and frustrating and annoying and everything else that it's going to be, we're going to have to accept the fact that we're going to live a little bit new normal. And if we do that, actually, we can live more normally, because if we don't do that, we're going to run the risk of a second curve. We're going to run the risk of a second outbreak. And a second outbreak would be devastating, obviously. And frankly, when it starts with more community cases like we have now, and you have a second curve, it would be far worse than the first curve. And so the thing I would urge is that everybody continue to do the things we've been doing right, and basically work together to protect each other. To me, it's a big social contract we all have with each other, which is to say, we're all in this together, and we'll ease restrictions and do that smartly, and we'll listen to the advice of experts and try to do this, recognizing patience is required, because nobody has the exact answers. And if we work that together, I think we'll get to a point where life will be not quite the same, but it's going to be one heck of a lot better than it is today. And we'll be able to do a lot of the things we really enjoy and connect with people and connect with faith communities and everything else that we want to do. And so I would urge people to work together with that. And, the last thing I'll say is we've been the recipients of so much goodwill, so many good wishes for the wonderful people on the front line, so much prayer, and it is deeply appreciated. And I just want to make sure everybody hears my profound appreciation for the support that we have felt.
Well, you've got it. And once again, thank you so much. Thanks for this time. Thanks for your overall leadership in our city, our state, our nation. We owe you a debt of gratitude. And
well, thank you.
Yeah, thanks once again. Dr. Marc Boom.
Thank you. It was nice spending time with you, Ken. Thanks. I look forward to seeing you in person.
Likewise.
One of these days.
That's right. Take care.
You too.
Well, okay, so there we have it. That's It wasn't exactly what I was hoping to hear. I think probably I, like many a pastor, would like to have heard green light, let's get back. And obviously, we didn't exactly hear that. At the same time, I bet I'm not the only pastor who cares for my people, and certainly my older people, and I don't want to do anything that would potentially cause harm. And so I'm grateful for the information. I want to assure those of you who are part of the Faithbridge family, we are assembling a team that's going to be working through copiously the details, the steps, as we are figuring out steps and learning steps from other people in a very real way. We're all walking across a bridge that we are building at the same time. It makes leadership very challenging and very important. So you be praying for us to have a lot of wisdom, and we'll continue talking to you along the way, most every day. This way, glad you could join us. Have a good evening.